All right. So welcome back for part two. Um, this seemed like the best way to break up this lecture. So now we're going to really start talking about the individual tests and measurements for PFT as we kind of with infection control and quality and the physiology. But now let's actually get into the tests. So there's three basic tests with pulmonary function: spirometry, lung volumes, and diffusion. Um, when we're looking to identify the presence of and degree of pulmonary disease, we typically um, are going to perform what commonly is called a complete PFT. So a lot of times physicians will order complete pulmonary function testing on a patient, and that means that you're going to do all three of these tests with the patient. Okay. Sorry, take a sip of something to. All right. So your spirometry test is your most common of the tests. Um, this test measures the air entering and leaving the lungs. So typically there's going to be several values that are measured. The ones that we care about the most are going to be your forced vital capacity, your FVC, which is the maximum amount of air that you can forcefully exhale from your lungs after maximum inspiration. Then you have your forced expiratory volume in 1 second. So this is the measurement of during that forced vital capacity, how much came out within the first second. There's other forced expiratory flow measurements that happen in there, but I don't want you to worry about those too much right now. But there are other measurements that are going to show up on those spirometry reports. So those measurements are going to be on there, but really when you're talking about diagnosing, you're going to be looking at these two, FEV1 and FVC. Okay. So when you're doing this measurement, you need to coach the patient to do to reach their inspiratory capacity, which is the total volume of air that you can get into your patient's lung during inspiration. So that's not just tidal volume, it's taking that big deep breath in. All right. So we instruct your patient to take a really big deep breath in. And you're going to then tell the patient to exhale forcefully and completely. So you're going to tell the patient to blast it out, and you're going to tell them to keep blowing it out, keep blowing it out, keep blowing it out until they've completely emptied their lungs out. And then you're going to tell them to take another deep breath in. Okay. So typically this test needs to be done at least 3 times to get that reliability. So I need 3 measurements, and those measurements need to be within 5% of each other to be considered reproducible or valid. Okay. There's other things that you want to look for on your spirometry test as well, like the presence of a cough, that would invalidate the test results, especially if it happens within the first second. Also, if you have the presence of like a breath hold at the beginning, if the patient fails to exhale for as long as necessary to get to that baseline, those are all invalid results, and the patient would have to redo the test. Okay. So again, this forced vital capacity is what we're measuring when we're doing a spirometry test. It's the most common test. All the measurements that we get are when they're performing that forced vital capacity maneuver, that deep breath in, blast it out, keep blowing, 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 till they can't blow out anymore, and then another deep breath in. This is extremely effort dependent. So if I'm in that chair and I take that deep breath in and I blast it out and I give it my all, I'm obviously going to be able to get more air out and it out faster than somebody that is sitting in the chair with their arms crossed and goes, and that's all they give you. So, 1 second, got to take a sip of my tea again. So when you're doing this and you're observing the patient, if you have I always use the term suboptimal effort for patients who aren't cooperating with me. I can kind of coach them through it. I can kind of explain what I'm looking for to try to get them to do it. But most of the time that works. I think I've maybe in all of the PFTs I've ever done, I've only ever had 2 patients where I was just like, nope, I'm not getting anything from them. They're just being a pain in the butt and they're not cooperating. And then I would write that and document that in the chart. For the doctor so that they know when they're looking at those results that they're not the patient's best effort. All right. So this is what kind of what that maneuver looks like on your screen. This is your volume time scalar. So what I'm looking for on this typically is that my patient's force expiratory maneuver starts right here at 0 second. If this curve starts further out like this and then goes up, this is called an extrapolation. Okay, this area here, and that also invalidates your results. And typically how I fix this with patients is what they're doing is typically taking that big deep breath in and then holding their breath, kind of doing a breath hold pause at that peak inspiration. And then sometimes a little bit of the air leaks out while they're holding their breath there, and that causes this extrapolation and invalidates your results. Okay, so that's what you're kind of looking for in this volume time scalar. Mostly I'm looking and troubleshooting for that extrapolation. On your forced vital capacity here, this is where you're measuring your flow rate and you're over your volume. So it's your flow volume loop. And this peak area here is what my peak expiratory flow rate is. Again, this is what gets confusing a lot of times for very new RTs is that peak flows, we do this in the hospital a lot to assess asthma, and is completely appropriate when you're dealing with acute exacerbations of asthma, but it is not appropriate to, you're not really judging anything off of PFT results based off of your peak flow rate. That isn't a factor that determines whether you're got obstructive or restrictive disease. The only thing that we look at with our peak flow rate is sometimes it tells me if I have a good effort. Because even a patient that has really bad lung disease, say this patient's very obstructive, their flow volume loop could look like this. This is a very obstructed flow volume loop. Okay, it could look like this. But the thing that I notice that I know that I had good effort is I still have a very distinct peak flow rate here. This is still my peak flow rate. It's lower than what, a normal patient would be, but it's still present. I still can identify it. Whereas if you have a patient who has just a crumbum effort, their flow volume loop is going to look kind of like this, where it's just a blob. It's just a blob. Where there's not much of an effort. There's no discernible peak flow rate here at the beginning. So I'm going to call this bad effort. This can also happen if there's a fixed obstruction in the airway. So this is where it comes into observation of your patient plays in. So if I'm having this and I'm noticing that my patient is truly making optimal effort, then I know that this is a fixed airway obstruction. But if my patient's just sitting there going and sighing, that's how this loop is going to look, and it's going to tell me that I don't have very good effort for my patient. Okay. The other things that we're looking at on this loop is, again, my peak flow rate. I'm looking at my flow, how much came out within the first second, and then how much came out total, which is my FVC. Okay. So typically when we do forced vital capacities, we are looking at we're trying to do this for baseline testing. So typically we tell our patients to not take their bronchodilators. So don't take their short-acting bronchodilators like albuterol or Atrovent. Typically we want to hold those for about 4 hours from the time of testing. Long-acting bronchodilators should be stopped about 12 hours before. And then typically we are going to do, we also will do pre and post bronchodilator testing with forced vital capacities. When we talk about pre-post bronchodilator testing, that means doing a baseline FVC and then giving a bronchodilator like albuterol and doing another one within like 10-15 minutes. All right, so some of the other measurements that you're going to be looking at is your FEV1. Like I said, that's the volume of gas exhaled in the first second. That FEV1 FVC is the most kind of important because it really shows that rate relationship and indicates whether or not the patient has an obstructive disease. And then this, FEF 1200 is that average flow rate in the beginning of the FEC maneuver. The FEF 25-75 percentage is that flow rate during the middle, and that peak flow rate again is at the highest. I would say the big ones you need to focus on again. Oops. Sorry. Oh, there's a lag, and when I want to use my little clicker thing, and that makes me screw up your progression here. So these are the ones that I think you need to worry about. All right. Last things to just say about FVCs before we move on to like MVVs and things like that is patients need to, we already said this, that they need to at least exhale for till they reach that expiratory plateau. So that usually needs to be at least 6 seconds, okay? So that expiratory flow plateau that I'm looking for is where I see no more air coming out of the lungs. So it's going to kind of flatline. And when we're in the lab, I'll kind of show you this. So in order for me to record all the results, again, I need to have at least three tests with my forced vital capacity being within 5% of each other and my FEV1 being within 5% of each other. Okay. And then I'm going to also look to make sure that I don't have, that my test was valid, meaning that there's no cough, there was no leak around the mouthpiece, there was no extrapolation that made the test invalid, and then that's considered 3 acceptable trials, right? All right. So now let's talk about MVV. Okay, again, this is going to be an effort dependent test. Okay, so during this test, the patient's asked to breathe as deeply and as rapidly as possible for at least 12 seconds. So you're going to tell the patient to breathe normally, and then then you're going to tell the patient to start breathing as deep and as fast as they can. So they're going to go like that for about 12 seconds is how long the window is. Okay. So this test is looking at like airway patency, it's looking at respiratory muscles, their ability to expand and contract. They're also looking for any hyperinflation or gas trapping in this maneuver. So when you're looking at your results are abnormal results or results lower than baseline are going to be dependent on that patient effort, how strong those respiratory muscles are, any compression of the chest wall and any obstruction in those airways. So normally your MVV should be somewhere between 160 to 180 for men, and it should be slightly less for women. Um, uh, if your measured value is less than 70% of predicted, so that what the patient was able to achieve is less than 75% of what's predicted, then that means it's abnormal. So it's usually going to be reduced in patients with some level of moderate or severe obstructive lung disease. It can be reduced in patients with restrictive disease, but if you have a patient that's malnourished or has like known neuromuscular disorder, you would probably understand that these results probably wouldn't be very accurate. All right. All right. So this is just some pictures of what your flow volume loop looks like, or the top of the flow volume loop looks like when you're comparing like normal to restrictive to obstructive diseases. So again, in normal diseases, the air is going to be able to come out very quickly. It hits that peak flow, and then the flow rate gradually slows down as we move through those get the flow out of those smaller airways till we hit their baseline. In obstructive diseases, obviously, I can't achieve as much of a peak flow because those airways are narrowed, so my flow rate slows way down. So instead of having a peak flow up here, my peak flow is only here. And then you notice that probably I'm going to have it's going to take me a lot longer to get down to that baseline. And then the more of the scooping out effect is more of like that tightening of those airways and the difficulty for that last little bit of air to come out. Okay, it's taking much longer for that to come out. You'll also notice with obstructive diseases that typically the volume overall is lower also, because if I have a lot of airway resistance in my obstructive disease, that decreased flow rate is also going to have a negative impact on my volume. With restrictive diseases, you see that my flow isn't an issue. I can get my flow rate out just fine. I get a good, nice peak flow rate. My flow comes back to baseline rather quickly as well. It's just my volume is a lot smaller than in a normal lung. My overall volumes are smaller. Okay. So this is, again, another picture from your book. It's just showing your flow volume loops. When looking at interpreting your data, you can, again, some of these shapes could be altered, not just by patient effort, but by the presence of like a fixed obstruction. Okay. So I mentioned this type of shape could be, poor patient effort, or it can happen, and it will be seen with patients who have like a solid obstruction in the upper airway. Okay. So variable upper airway obstructions are going to produce two different shapes depending on the site of the obstruction. Okay. If the intra airway pressure, if the variable is extrathoracic upper airway obstruction, such as something that's going to occur in the trachea, so outside of the thoracic cavity, but in the trachea, this is going to limit inspiratory flow, right? Because the trachea is a big tube, it's going to affect how inspiration happens more than expiration, right? And flatten that inspiratory portion of the curve, okay? So this is where it's going to flatten that inspiratory, as seen in this one here. In patients that have intrathoracic obstructions that are variable, like something that is inside the airway, that is going to have a flattening effect of the expiratory side. Okay, so if it's an obstruction that's inside the airway, it's going to flatten that expiratory side. If it's an obstruction that's affecting kind of that's outside the airway but compressing the airway, it's going to affect the inspiratory side. Hopefully that made sense. This is an example where it's affecting both inspiration and expiration. So if I had like a vocal cord paralysis that is affecting inspiration and expiration, it might look like this. Okay. All right. All right. So that reversibility of airway obstruction, we talked about FVCs and doing a pre and post. So if we suspect that an obstruction is present, we must evaluate if it's reversible or not. Okay, so think to yourself about what types of lung diseases benefit from bronchodilators. Okay, not every lung disorder is going to benefit from a bronchodilator, right? What do bronchodilators do? They provide smooth muscle relaxation in the airways. So that is how it helps with bronchoconstriction. So if my kind of pathophysiology of the disorder that I'm talking about doesn't involve bronchomuscle constriction, bronchodilators aren't going to help it. And this is where it comes into play with sometimes that emphysema patient versus the chronic bronchitis and the asthma patient, because emphysema truly isn't bronchoconstriction typically. It's usually kind of those destruction of those airways and the scarring of those airways. There's not a lot of bronchoconstriction with it. So like a truly just emphysema patient might not have a big change. You might not see a big change in their pre-post bronchodilator. But like an asthmatic or a chronic bronchitis patient, those patients do have some level of bronchoconstriction that's causing the obstruction, and they will show a significant change pre-post. Okay. So how we do this is we just perform that baseline spirometry. Then we typically give like 4 puffs of an albuterol inhaler, or give them a unit dose of albuterol, give them 10 minutes to have that get peak effectiveness, and then we're going to repeat the spirometry maneuver. And if we see a 12% or greater improvement in that FEV1 or FVC, then you would consider that effective and reversible. Okay. Another test that we do related to FVCs is bronchoprovocation challenges. So this is methacholine testing is what most people call it. This is indicated when you really think the patient has asthma. So there's stuff in the patient's history that suggests hyperactive airways and airway obstruction. But they come in for their pulmonary function testing, and it doesn't really show that on their pulmonary function report. Okay, so the doctor's going to sit there and scratch their head and be like, I really think it's asthma. Then they might order the patient to come back and do this bronchoprovocation test, which is using an agent to stimulate essentially an asthma attack and create that airway obstruction that we can document on a PFT result and call asthma. So what we're doing during a bronchoprovocation test is we're using an agent, usually methacholine, to stimulate those airways, cause that asthma attack, and document that decrease in pulmonary functions. So typically when you do this, you should always do a control forced vital capacity. So typically I'm going to start off with a baseline. I'm going to get the patient's baseline. I'm going to make sure that there's no obstruction shown on their baseline. If the patient's already obstructed on their baseline spirometry, then I'm going to call the doctor and say, we don't need to do the bronchoprovocation test because they're already obstructed. I'm not going to give them this then and make it worse. So if if their PFT is normal at baseline, then I'm going to start the test by giving you're supposed to call it a diluent dose, which is usually the diluent for methacholine is saline. Sometimes it has a preservative in it. So you give just the diluent that's used for the methacholine mix, redo the FVC maneuver, see if there's any change, okay? If the patient drops just by getting the saline, their FEV1 drops 10% or greater just by getting the saline or the diluent, then that's a positive test and they've got hyperactive airways, okay? If they don't drop, then we're going to start in with the methacholine agent. So we're going to start with the smallest dose, lowest dose first. They're going to inhale this agent. They're going to repeat the FEC maneuver. And if the FEC maneuver is within 20% of baseline, then I'm going to go to the next higher dose. And I'm going to keep doing that until I see that drop of 20% or greater in that FEV1. Okay, so let's say I start off my procedure. Again, I start with a baseline FVC. So usually you do at least, this is 3 maneuvers, right? Because we always have to have them repeatable and reproducible. So we usually get 3 for your baseline. Then I'm going to do the diluent one, and I'm going to do an FVC, and I'm usually going to repeat that at least, I want at least 2, depending on your PFT lab. Every PFT lab I've ever worked in just makes you do 2 because it's a lot of them then. So now we're up to 5 FVC maneuvers. Then I'm going to do the first dose of methacholine, which is usually it's usually, if you're going to be specific, 0.025 milliliters. Okay, and then I'm going to do an FVC, 2 of them, and make sure that it's not within 20% of baseline, or I'm going to make sure it's within 20% of baseline. Okay, so if I started off at, let's say, 100 for my FEV1, as long as this is above 80, I'm within 20% of my baseline and I'm good. Then I'm going to go up to the next dose. So a lot of labs do quadrupling doses. So then I would take this 0.25 milligrams, multiply it by 4. Some labs do double dosing. Quadruple dosing is faster. So that is why it's I feel like the better choice. So then this would mean that my next dose is 0.1 milligrams per milliliter. Okay, I'm going to do an FEC times 2. Okay, and as long as my FEV1 on that FVC is greater or within 20% of baseline, I keep moving on. And then the next dose, I'm going to quadruple it again. And then that's your 0.4. And then you're going to 1.6. 6.4. It's like 25. Okay, so that's kind of how you can see how the dosing goes. If any point along this way, like I get to maybe this dose, and at this dose my patient's FEV1 is 22% less than what we started at, I'm going to stop the procedure. I'm not going to give this final dose, and I'm going to just give albuterol. Okay, so that's kind of how you do that methacholine challenge. And again, we'll practice this in labs so you can kind of see this real time and you can kind of get the idea of what it's like to do this. Okay, if you get to that top dose, that max dose, and you don't have that 20% drop, then I guess you don't have asthma and we need to look for a different culprit for all your woes. Okay. Lung volumes and capacities. All right. So these guys. So typically when I start my and I would have laid this book out differently, I guess, because when I have a patient that comes in for a complete PFT, the first test that I'm going to do is usually my lung volumes test. Even though spirometry is the most common, I usually start with my lung volumes. So if I do my order of operations here, and I have to do, I'll do lung volumes first, which is a slow vital capacity plus plethysmography. And then I'm going to do my pre-spirometry or pre-FVC. Okay. Then I'm usually going to give my albuterol. Then I usually give my albuterol because then I can do my DLCO. DLCO usually isn't affected by a bronchodilator. So while I'm waiting for that bronchodilator to work, I get my DLCO squeezed in, and then I finish with my post bronchodilator. So this is typically how I've always done my PFT testing. And that is because your spirometry, if I do a forced vital capacity first, that can cause bronchospasms and make it difficult for my patient to do that FVC. I have to do my SVC, my slow vital capacity, before I get my bronchodilator, because that's going to be affected by it. But like I said, my DLCO can be done afterwards. So that's usually my order of operations. So when we're talking about lung volumes then, these are usually, we're talking about 4 volumes that make up in different ways 4 capacities. Okay. So your 4 volumes are going to be get out of here. Sorry, one second. Ugh. Your 4 lung volumes are going to be your tidal volume, your inspiratory reserve volume, your expiratory reserve volume, and your residual volumes. Okay, so your tidal volume is the total amount of air that you get in and out of your lungs with a normal respiration, right? So that's your tidal volume. Your inspiratory reserve volume is the maximum amount of air you can breathe in. Your expiratory above your tidal volume. Your expiratory reserve volume is your maximum amount of air you can breathe out below your tidal volume. And your residual volume is the amount of air that stays in your lungs forever and you can't measure directly or breathe out. Okay? Your lung capacities are going to be your total lung capacity, which is all of these volumes added together. Your inspiratory capacity is going to be made up of your inspiratory reserve volume and your tidal volume. Your functional residual, I should probably be typing these out for you. So your total lung capacity is your tidal volume plus your IRV plus your ERV plus your residual volume. Your inspiratory capacity is your IRV plus your tidal volume. Your functional residual capacity is your ERV plus your RV. And your vital capacity is your IRV plus your tidal volume plus your ERV. Okay. And this is why I think it's just better, instead of trying to remember those formulas, is to memorize this chart. Okay. So again, your tidal volume is kind of your resting volume. It's how much air you get out in and out of your lungs in that typical breath. Your inspiratory reserve volume is your maximum inhalation, right? Your expiratory reserve volume is the volume at maximum exhalation. Your vital capacity is everything added together, right? Maximum inhalation to maximum exhalation. All right. Your total lung capacity is all of these things added together. Okay. And depending, and you guys got this on your mock exam, you had a lot of questions that related to this. I think there was at least 2, maybe 3 questions that you could have answered based on having this accurately drawn on your piece of paper. So I think that just having this as a reference on your piece of paper is important. And then again, practicing the questions with it so you know how to like use it, right? Because you're going to be asked questions like, I've given you an IRV, a tidal volume, and a, let's think here. I've given you an IRV, a tidal volume, an expiratory or a vital capacity, and an expiratory reserve and a functional residual capacity. And I need you to calculate out your residual volume. So you're going to have to do some math to figure out how to find this missing value. And if you plug them into the chart, it'll be really clear which ones you have to add together and subtract from to make up this number here. Okay, so having this schematic written out on your flow sheet is important. Remember, we've heard the term vital capacity before. We've used vital capacities in mechanical ventilation, right, as a measurement to indicate, respiratory muscle strength. So if your vital capacity is less than 10 milliliters per kilogram, that means that you're not ready to wean. Or if we're talking about disease management, if your vital capacity is less than 10 milliliters per kilogram and you have neuromuscular disorder, that's an indication for intubation. Okay. So I mentioned that all of these volumes I can measure directly, but this volume down here, this is a volume of air that stays in my patient's lungs and doesn't get exhaled. So I have to indirectly measure this volume. So there's a couple different ways that this can be done. Okay. Every lab, this is the most appropriate way is plethysmography. So plethysmography is the best way to measure your RV. But plethysmography requires a patient to sit inside a closed box and perform a maneuver where they have to keep their mouth tightly sealed around a mouthpiece. This maneuver, when you guys go get to have this done on you, when we go to the PFT lab, it's difficult to do it right. So not every patient can perform an accurate plethysmography. Not every patient can tolerate being shut into the closed box. I had like a 7-foot tall guy in the PFT lab once where I was like, and he was old. He was like an old ex-basketball player back when like Sheboygan had a national an NBA basketball team or some sort of like professional basketball team. So he was a holdover from that, and he was like 7 years old and he could not bend his knees anymore, and he was ginormous, and there was no way I was going to get him to bend his knees and get into the box and be able to shut the door. So we had to choose a different method. I've had patients completely freak out and get claustrophobic or super anxious doing plethysmographies, and then I've had to go to a backup. So typically any PFT lab, even though this is the gold standard, one of these backups should be available. Most labs typically use nitrogen washout as their backup. So what helium dilution is it is based on the fact that you will know the amount of helium that is being delivered to the patient. And what you're looking for is for that helium to come back. So the patient's going to be breathing in this known quantity of helium, and they're going to just tidal breathe through this closed circuit with this known quantity of helium. And as they kind of breathe this gas in, that helium concentration is going to like equilibrate in the lungs. So there's kind of a nice picture of that in your book of when, everything, when it's reached an equilibrium. And then this will allow the patient, that will allow us to be able to kind of calculate out what their RV was based on how long it took them to equilibrate. So typically about 2 to 5 minutes in a normal healthy patient. But if you have an obstructive disease, it takes you a lot longer to equilibrate with the helium. If you think about what your RV is, it's the amount of air that stays in our lungs after peak exhalation. So patients with obstructive lung diseases are going to have higher RVs because of that gas trapping. So think about this as a volume that gets trapped in your lungs. So who's going to have more gas trapping? Patients with obstructive lung diseases. So helium dilution will be much longer in an obstructive patient. Same with nitrogen washout. So nitrogen washout is based on the fact that we're typically breathing 78%, 79% nitrogen in the room air that we breathe. Okay, so 78 and 79% of the volume of gas that's stuck in our lungs is nitrogen, is made up of nitrogen. So what the patient does during nitrogen washout is they're not breathing nitrogen, they're actually breathing 100% oxygen. So we are going to they're going to perform it kind of like they do the helium dilution, where they're going to be breathing through that closed circuit, just tidal breathing. And we're going to be they're going to be getting 100% oxygen though. And we're going to be measuring to see when they start exhaling 100% oxygen essentially. And then that tells me that we have replaced all of the air that was trapped in their lungs with now oxygen, and I can calculate out their RV. Okay. So plethysmography is the, like I said, kind of the best technique. This uses Boyle's law about volume and pressure changes to determine that lung volume. All right, so it measures the volume in the thorax, right? It's measuring the volume through the mouthpiece. And it's also measuring like the pressures inside that box. Okay, so this patient is going to sit in a sealed chamber. Okay, there's going to be pressure transducers that are going to measure the pressure at the mouth and then inside that chamber. There's also going to be some, you're going to eventually in the testing, you're going to hit a button that's going to close a shutter in the mouthpiece. That's going to occlude that airway for a short period of time. And then that's going to help us measure those airway pressure changes under the conditions where there's no airflow. And that is going to indicate those pressures in the alveoli. Okay. So again, there's a lot of physics behind this and a lot with Boyle's law, where you guys all hated gas laws the first time around. I think it makes more sense when we do it in the lab. Okay. So this the significant thing to know is that this is the best way of obtaining an RV is through plethysmography. Okay. Because it measures that entire chest volume. Okay. All right. Okay, so when we're interpreting lung volumes and capacities, so again, these are volumes. So any abnormalities with this are usually related to restrictive diseases. So if your TLC is decreased, so it's less than 80% of predicted, then that indicates a restrictive disease. Okay. If your RV is increased, that means there's more air that's trapped in the lungs. That can cause your FRC to be increased above what's predicted, and also your TLC to be increased above what's predicted. So if you have a patient who's obstructive lung disease, I would expect to see an increased RV. It could be normal, or you could have the increased RV, increased FRC, and increased TLC. If it's a restrictive disease, you're going to see a decreased TLC is what you're looking for. Okay. I think ATS standards say that your TLC RV ratio the ratio between your TLC and your RV should make up no more than 40% of your total lung capacity. So if your RV is making up more than 40% of your total lung capacity, that indicates that you have an obstructive lung disorder. And I would want to verify that then with spirometry. Okay, if on my spirometry it doesn't show an obstructive lung disorder, but my RV is elevated, then I have some error in my testing somewhere, because those two things cannot be separated. All right. Let's talk about diffusing capacity. So this is the lung function test that's looking at the transfer of gases across that AC membrane. Okay, so the things that are going to impact this is those pressure gradients, the characteristics of the gas in question, so like the size of the gas molecule, and then the characteristics of that AC membrane, like the thickness of it and its surface area. Okay, so we use carbon monoxide to measure my diffusing capacity. Okay, so that's what this stands for. DLCO stands for diffusing capacity of the lung for carbon monoxide. Okay, it's going to be how the patient is going to do the procedure is usually they're going to do like a single breath technique where they, breathe normally, and then you're going to tell the patient to take a kind of deep breath in and exhale completely, get all the air out, like just like a slow vital capacity. And then they're going to rapidly breathe in to their total lung capacity. Okay. And when they do that second deep breath in, that is going to be a known concentration of carbon monoxide and helium. Okay. They have to hold their breath then for about 10 seconds and exhale it. Okay. And as I exhale it, I'm going to be measuring kind of the concentration that came out of the lungs. Okay. Okay. So the things that are going to affect this is going to be like anemia. So if I don't have hemoglobin for it to diffuse into, that's going to decrease my DLCO. If I already have a high presence of carboxyhemoglobin, meaning typically who has a high level of carboxyhemoglobin is your smokers. So typically we tell our patients not to smoke on days of testing because it will affect this. Patients that have perfusion issues like pulmonary embolism, or if they have a diffusion problem like pulmonary fibrosis or emphysema. Factors that are going to affect or increase DLCO are going to be, you have like a lot of hemoglobin, polycythemia. It's going to your diffusion rate is going to be faster. If your patient is exercising, they're going to diffuse quicker. If they have congestive heart failure, that can cause an increase in diffusion. So typically, because of some of these factors, we usually like to report this with a hemoglobin level. So typically you'll either get a hemoglobin level, there's non-invasive hemoglobin measurements that you can get. So most labs will have like a non-invasive finger probe thing that they'll put on and get a hemoglobin, or the patient will get an ABG with a hemoglobin during testing. So with this procedure, you want to make sure that the patient's resting in that seated position and haven't been like running a mile right before they did this. And that you want to make sure that they're not breathing any supplemental oxygen before the test. So usually we withhold that for about 10 minutes before testing. Okay. So if a patient is on home oxygen, it's very difficult for them to wear their home oxygen when they're doing PFT testing because they're usually sitting in a box with nose clips on. So they're usually not wearing their oxygen anyway, but at least 10 minutes before the test, you would want to make sure that they're off of it, and that if you're doing the sequence of testing like I typically do, where I'm giving my bronchodilator and then I'm doing DLCO testing, I want to make sure I'm doing that with room air, not with oxygen. All right. I think that's what I want to say about that. Okay, so significance of some of the results. I already said this, TLC, FRC, RV can all be increased with obstructive disease, and these can be decreased if there's restrictive impairment. Okay, so if it's greater than or less than 80%, that's considered restrictive. If those numbers are greater than typically like 120% of predicted, then that would indicate that it is potentially obstructive. Okay. So it's not super important to know kind of these normal values in liters. Mostly you're going to worry about them in regards to percent predicted. Okay, so again, this is kind of a nice picture that's from your book that just shows how in a restrictive disorder, all of these values are decreased. In obstructive disorder, my IC typically isn't, my IRV, IC, those aren't typically increased, but my FRC is bigger, my residual volume's bigger, and because those two things are bigger, my TLC is bigger. Okay. Okay, so diffusing capacity, when you're looking at your results, you may see low results in both obstructive or restrictive diseases. So an obstructive disease that has a low diffusion capacity would be emphysema. A restrictive disease with low DLCO would be pulmonary fibrosis. So those are two of our most common reduced DLCOs. So if you had a test question that asked you to interpret PFT findings, you have that DLCO that's less than 80% of predicted, that means it's decreased. If they also show an obstructive disorder, you would make the diagnosis of emphysema. If they also show a restrictive disorder, you would make the diagnosis of pulmonary fibrosis. All right. I think I already went over this. I must have had a duplicate slide here. So the most common is that single breath technique. I think the only thing I missed from when I was talking about this earlier, is just you have to wait in between attempts. So again, you still have to reproduce this test. You can't just do a one and done. You have to, for reliability purposes, I have to repeat this test. But because my patient just breathed in some carbon monoxide, I want to wait at least 4 minutes and sometimes maybe even up to 10 minutes to get that CO2 from the lungs and get more accurate results. So typically I'll do one, I'll wait 10 minutes, and then I'll do the other one. And then usually by that time, there's been enough time, and then I can do my bronchodilators. There's not enough carbon monoxide in this test to cause any sort of problem for the patient. It is a very, very, very low amount. All right. So your PFT interpretation with your patient, okay. So when you're interpreting your PFT reports, there's a lot of different strategies out there for doing this. A lot of pulmonary function testing equipment has like software that will interpret it for the doctor, just like EKGs. But again, You always need that human eye on it to make sure it's accurate. So typically what we're looking for again is that FEV1 FVC ratio to look to be where we kind of start. So I'm going to look at that FEV1 FVC. If it's less than 70% of predicted, then I know I have an obstructive disease. Okay. Then I can go on and look at my TLC. Okay. I can look at my TLC and look to see if it's, you know, within the normal limits, or if it's lower than that lower level of the normal, then I am going to consider this a restrictive disease. So less than 80% of that lower limit of normal is going to be restrictive disease, right? Your DLCO, again, if that's less than 80% of predicted, then that is a diffusion defect, okay? So FEV1 FVC, first and foremost, I'm looking at that guy, and I'm looking for this to be less than 70% of predicted. For my TLC, I'm looking for it to be, if it's less than 80% of predicted, then I've got restrictive disorder. My DLCO, if it's, oops, I did that wrong, less than 80% of predicted, then it is a diffusion defect like emphysema, or this is less than, get my alligator going the right way. So TLC less than 80% of predicted, that's restrictive. DLCO less than 80% of restrictive, that's diffusion defect. Okay, so I will give you guys, when you guys are in lab, a couple examples to interpret, and you will expect to have some interpretation on the exam. All right.